Let's talk about the hard stuff, the non-invasive hemodynamic monitoring. This is a lecture that Dr. Csaba Diaszegi, he's head of our critical care department at the college, and he's putting together our master's in pre-hospital critical care. And I am designing the austere critical care side of that master's degree. We're about ready to submit it. This disease, this pandemic has kind of put a halt on a lot of the stuff we're trying to do, but we're trying to get this master's degree up and running. So a lot of this lecture came from Dr. Csaba, and I appreciate his help with this. He's critical care, board certified critical care, board certified emergency medicine, board certified pre-hospital doc. He's got a head about this big. He's really good. So so he's going to have a lot of this content. So what we're going to talk about, and we got literally 55 minutes. How to assess hemodynamic. We're going to get the basics of hemodynamic, the cardiac output, preload, afterload, contractibility of the heart, vascular resistance, and volume. And we're going to be able to interpret data using non-invasive means to get your CVP. Of course, your blood pressure is easy to get. Cardiac output is pretty easy to get. Cardiac index is a bit of a problem. And your systemic vascular resistance is a bit of a problem, but we can do that with calculations. And we're going to have case studies at the end of this on differentiating between shock states just using hemodynamic parameters. We're going to talk a bit about vocabulary. Contractibility is how strong your heart muscle can contract. And we have drugs to make it stronger. We have drugs to kind of quiet it down a bit. Cardiac output is the amount of blood pumped in 1 minute. And there's two variables with that. Preload is the end diastolic volume filling the ventricles of the heart just before the contraction. Afterload is the pressure of the wall of the left ventricle after all the blood is left, or what little blood is left in the left ventricle after it squeezes. That's the afterload, and that's going to be a force that kind of counters new blood trying to come in because it's already pressure and you're trying to add pressure in. We'll talk about vascular resistance, which is your whole system's push against the heart. These are the ones you guys, I want you to really focus on. Central venous pressure, we can measure. Your blood pressure, systolic and diastolic, well, you can measure. We've been doing that since we first started medicine, didn't we? Mean arterial pressure, we talked about that, the difference between your systolic and diastolic, and 1/3 of the difference between the two. And it's one of the gold standards we're looking at, right? Mean arterial pressure. Looking at cardiac output and your systemic vascular resistance. So let's start with some basics. We've already talked about your primary vital signs, which is your C-Pro, capillary refill, pulse, respiratory, and pulse oximetry. And we can get a lot of information just out of those four things. We get them very quickly with just wham, so we throw this on the casualty and boom, we've got C-Pro. Secondary vital signs, what we call BEAST, just what the college uses to help remember what they are. Blood pressure, ECG, alert status, sugar status, and temperature. On top of that is your JVP, your jugular venous pressure, ETCO2, which is pretty much a gold standard as well if you have it. I haven't mentioned it up to this point because we don't always have that. It's just not something that's especially the blow-by stuff. So a lot of the hospitals I've worked at in austere environments, if they have ETCO2, it's only going to be in line. It's not going to be the blow-by. So, but that is kind of the gold standard as well. CBC and Chem7, our chemistry panel, is going to give us a lot of our hemodynamic status as well. Lactate. Now, there are lactate monitors that are pretty cheap. They come out about this size now. We've got 2 of them down at the college. They do 4 different variables. And as a critical care practitioner, lactate is something you're going to want. It's going to tell you how much of your respiratory system is happening in the metabolic side that doesn't have oxygen. So if your body is trying to make trying to make power with ATP and you don't have oxygen, it can do it, but then it has a byproduct of lactate. So if I have high lactate, that means, my body is not having a good time getting cellular respiration, which is an oxygen problem. So that's why lactate is pretty important for a critical care practitioner. An increase of lactate is going to tell me that there's an increase in epinephrine use. The increase, there's burns, sepsis, acidosis, hypoxia, heart failure, excess exercise. These are all going to cause lactate. And you hear muscle-bound guys and girls talking about, oh, dude, my lactate, yeah. So it's because they're only looking at the lactate byproduct of overuse of muscles. So CPRO, this is absolutely first thing you need to think about. Just get your pulse oximetry and get your CPRO. It's going to tell you a whole bunch of information very quickly. Your capillary refill is a quick hemodynamic status, because if you have more than 2 seconds to refill, there's something going wrong with your hemostatics. So we are going to do your capillary refill, but you know what? We don't do it here, because in an austere environment, you're going to be in a hot environment, you're going to be in a cold environment, and this is going to be decreased normally. Like everyone in your expedition has decreased cap refill here because it's cold. They're all hemodynamically stable, but they're cold. So we're going to look at central. So I'm going to get my thumb right on my sternum. I'm going to press for 5 seconds, and then I'm going to look at my capillary refill on my sternum. Sure, yeah, why not? You can check as well, yeah, but it's not what we're looking for as critical care practitioners. Heart rate, respiratory rate, SpO2, these are all going to tell us if there's hemodynamic issues. So your CPRO is the first port of call when you're trying to find out hemodynamic problems. With your SpO2, you have a waveform. It's a waveform that, until I took my critical care paramedic course, I was just like, oh yeah, dude, hey, there's like a waveform. Hey, cool. I didn't understand the information you can learn from your waveform of your pulse oximetry. And it kind of, it has mirror to the aortic waveform that you have as well. So you can find your systolic pressure, which is the top of the waveform, and the diastolic pressure, which is the bottom of the waveform. I'm going to turn on we have a whiteboard here. So I'm going to draw a line here. This waveform top, that's your systolic pressure. And the bottom of your waveform is your diastolic pressure. So your pulse pressure is the difference between the top wave and the bottom wave. So that tells me that my waveform is going to tell me if I have a fever, anemia, bradycardia, heart block, it's going to make my waveform really narrow. Or if I'm going to shock, if I have a drop in stroke volume, if I have a drop in fluid because I have diarrhea, or I'm sweating everything out, or I've bled everything out, my waveform is going to get wider, and it means my peripheral resistance is going up, and possibly some sort of, could be pumps, pipes, or fluid problem. We'll talk about that in a bit. Something's going on because my waveform is going like this. My waveform goes like this. It means that I'm having bradycardia or heart block or something like that. So your waveform is going to give you a rough idea of hemodynamic status. So pumps, pipes, and fluids. This is your bread and butter of hemodynamics. And what we're looking for, number one, is a map. So our mean arterial pressure, again, so this is my diastolic, this is my systolic. My map is 1/3 of the distance between my diastolic and systolic. And we'll talk about some math problems you can do to figure it out precisely, but I'm lazy and not that smart. So I'm going to use 1/3 of the distance between my two blood pressures. That map is going to tell me that I'm perfusing. If it's above 65, my kidneys, my brain, my liver, my heart, everyone's happy because it's above 65. You know, better would be 70, but 65 is where the kidneys finally were like, you know what, I've had it. I can't do it anymore. So we need to have 65 or higher. So that goes off of your blood pressure. So the better the blood pressure, the better your map. So let's talk about what makes map. What makes your mean arterial pressure? It's pumps, pipes, and fluids. So let's talk about fluids. Number one, fluids. Number 2 is your pipes. Number 3 is your pumps. So let's talk about fluids. So assessment for your fluid status, you can get your history from your casualty of, I've been diarrhea for 3 days. We probably have a volume status. Pump might be fine. Your pipes might be fine as a volume. So get a history from them. You can look at collapsed jugular veins. You can look at dry mucus. So look at the mouth and compare with everyone else and see if they have dry mucus. On skin turgor is another one. So you can lift the back of the skin, and if it stays up like that, that means that you have a volume problem. So what to do? Well, CABC, right? Stop the bleeding. If you have some fluid leaving the body, stop that fluid leaving the body. So if that means diarrhea, if that means bleeding, if that means whatever it is, stop that fluid from leaving. So give whatever fluid they lost. So if they lost blood, we give blood. If they lost water, we give water. So, they lost salt water, we give salt water. And we monitor the response. We do a bolus. We do a fluid challenge. We give them 500 mils IV of fluid and see what happens. And their skin turgor goes away. Hey, brilliant. You just sorted the problem. So that's one of the 3 problems that can happen with your MAP. That cause MAP to drop is your volume status, your fluid. Let's talk about pipes. So your pipes can get really big if you have anaphylaxis. Your fluid is fine. Your pump is fine. Your pipes are big, and therefore your MAP drops, your blood pressure drops. So you can assess your pulse pressure. So a narrow pulse pressure means you have a higher systemic vascular resistance. You can also check the peripheus. So if they're shunting because they have a pipe problem, then your hands are going to be cold, arms going to be cold, up here is going to be warm. So that's telling you something. Your core skin temperature difference. And your capillary refill could be going up because you're not getting the fluid into your extremities, or if you check centrally. What to do? If you have low resistance, such as sepsis, anaphylaxis, neurogenic, you need to give drugs. You need to give a vasopressor, epinephrine, norepinephrine. We'll talk at the end. We'll talk about the different drugs you can give and what it does to the casualty and what you want to get out of it. So let's talk about, so we talked about fluid problem, we talked about pipes problem, we talked about pump problem. So if there's a pump problem, there's going to be fluid in the lungs, you're going to hear crackles, you're going to have JVD, distension. So we can treat arrhythmia. This is normal ACLS stuff. It works in austere environments as well as it works in city-based. So just find the arrhythmia because you have an ECG, right? We already talked about you always have an ECG. So find out what that arrhythmia is and try to go through your A's and T's and figure out what's going on with your pump. Golden rule. We've talked about this. Let's talk about it again. Urine output, at least 1 mil per kilo per hour. Always. And you want to check this longitudinally. If they have it 1 hour, that's not good enough. And every hour has to be, on average, 1 mil per kilo per hour. Now, people don't wee every hour. Sometimes they wee every 3 hours. So that means that at the 3rd hour, they should be getting 3 mils per kilo per hour because over the 3 hours. Mean arterial pressure is 65 or higher. Urine output of 1 mil per kilo per hour. And that is the number 1 and 2 thing that you're looking for as a critical care practitioner. Also looking for field assessment as you have more and more systemic vascular resistance because your body is shunting, or your body is, or let's say you give a bunch of epinephrine and your body, that increases your SVR, and suddenly your hand's going to be cold, and then that's warm, and that's warm. So what I'll do is I'll get a biro, I'll get a pen, and I'll draw a line on my hand. Like, all right, this is cold, this is warm it's 1816 right now in Central Time. I'm going to write 1816, 16th of April, the line was there. And then an hour later, I check, and the line goes up. Well, you know what? I'm doing something wrong because he's getting worse. This is called trending. We talked about trending. So I'm going to get a line here. It says, all right, at 1900 hours, it was here. And that's how you're going to do a trending assessment of shunting, of a peripheral skin problem. If you're getting cold, and it could be environmental because we're in austere environments, but generally, if you have them in your tent, you keep them warm. They have a hypo wrap, the thermal wrap, because you're trying to warm this critical casualty, and their peripheral vascular resistance starts to improve, or not improve, get worse. You need to document this out. This is going to tell you something is seriously wrong with your casualty. Let's talk about blood pressure. There's 5 variables that we'll talk about on what causes increase of your blood pressure, and we'll map. That's what we're looking for, isn't it? What makes map change? So stroke volume times heart rate is your cardiac output. So your average stroke volume, 75 mils, give or take. I'm a big guy, it might be more. My wife's smaller than me, she's gonna be less. So, but there's some math we can do to give you a more precise cardiac output. Compliance is how expandable the pipes are. I'm in my 50s. My pipes aren't as expandable as they were when I was a child or when I was in the Army in my teens and 20s. So my compliance means my BP is going up as I age. It happens because my compliance isn't as good. Overeat rehydration is going to increase your MAP. Hypovolemia is going to decrease your MAP. Viscosity of the blood is how sticky is the blood. The stickier the blood is going to change your blood pressure. And we have, clopidogrel. We have aspirin, things that can actually change the stickiness of the blood. And blood vessel length and diameter. If you're in anaphylaxis and your diameter gets big, your MAP is dropping like a rock. Okay, let's take a look at this. We're going to see a lot of this. And this is, we put this, Dr. Diasegui designed this first, and then I kind of removed all of the ones that require a Swann's catheter to invasive monitoring. And the only thing left is the non-invasive, which as austere critical care practitioner, this is what you need to know. And to be fair, I wonder if Dr. Chuba in the base of Mount Kilimanjaro would put a Swann's in either. He would probably rely on the non-invasive capacities of ways of getting your hemodynamic monitoring, because it's just too dangerous to put in some of these invasive toys that he gets to play with. So here are the parameters: your systolic blood pressure, diastolic blood pressure, and then of course your MAP is calculated right there. So those two give you your MAP. MAP is one of our golden rules. So we're going to look at your central venous pressure. We can measure that. Your systemic vascular resistance, you can calculate that. Your cardiac output, you can calculate that. And your cardiac index can also calculate that. So these are the variables we're going to discuss. How to measure these. The first 3 I put in green because we've been doing this since we first started. I started as an EMT in the late 80s. We've been doing this. I've been doing this since the very beginning. So everyone has the ability to get systolic, diastolic, and MAP. So the second one is vascular resistance, and we'll talk about how to measure that. And the third one is your cardiac pump performance, and that's going to be more calculation because we don't have. There is a way to calculate your stroke volume because you have a little wire goes in through your brachial, your subclavian, all the way in. We're just not going to do that in austere environments. Your MAP is 1/3 of your pulse pressure. So this is your diastolic. This is your systolic. So I'm going to calculate my pulse pressure, which is the difference between my systolic and my diastolic. That's my pulse pressure. And 1/3 of that gets added to my diastolic. So that's my MAP. Now for our anesthetic docs on faculty with us and Dr. Chuba and other critical care docs, that's just not good enough. They need a little more precise measurement. Now they can do that with their invasive wires that go all the way in, but you can also do this by a more mathematical way. So MAP is your systolic blood pressure times twice your diastolic blood pressure divided by 3. You can use that if you want. I'm lazy. I'm going to guess, and it's a rough guess. So either way you want to go, you're fine. All right, so pipes, pumps, and fluids is what's going to be variable for our hemodynamic monitoring. So the pump problem, when there's a pump problem, it's going to be a right side or left side or both pump problem. And the measurement of the variabilities of your preload and afterload is going to vary, and that's going to be something for your hospital-based critical care. In pumps, we talked about resistance. Vasoconstriction is going to increase resistance, and your blood volume is just the amount of fluid you have. So those are your pumps, pipes, and fluids. Cardiac output is stroke volume times heart rate. And assuming we have 75 mils of stroke volume, we can kind of get a cardiac output, but why not look at this a little more deeply? So there's your stroke volume and heart rate. Your stroke volume depends on your preload, the contractibility, the ability of how much your heart can contract, and afterload. So each one of those three has a say on what stroke volume is. If you have a lot of preload, which means the pressure going into your right atrium is increasing the amount of fluid going in, that means more blood is in the heart, and as it pumps, it goes out and increases your stroke volume. And then depending on your heart rate, you can kind of calculate that. Now, heart rate is a variable it's a balance of your parasympathetic, sympathetic, and sympathetic. So your heart rate goes up due to your sympathetic, and your heart rate goes down because you're parasympathetic. And there are a lot of variables in there that's going to cause that. We have drugs that can do both, and we can adjust the heart rate up and down as we see fit. But those are the 5 variables of your stroke volume and heart rate. The cardiac output can be calculated a little easier. Your pulse pressure times your heart rate times 2 is the cardiac output ish. It's some good research behind it, but it gives you a rough estimate. So my pulse pressure is the millimeters of mercury difference between my diastolic and systolic. So if I have pulse pressure of 40 millimeters of mercury, I'm going to times that by my heart rate, which is 60, and then times that by 2. So that's 240 is 480. So my cardiac output is 480. So I can either use this method to calculate that, or I can use this method and calculate that. I would encourage you to know this way of calculating your cardiac output. It's easier. Vascular resistance can be calculated by having your MAP minus your CVP divided by your cardiac output. So we just learned cardiac output. That's in the denominator. That's in the bottom. So my MAP, let's say it's 40, minus my CVP, which is, let's say, 8, because we can measure CVP. I don't remember if I put this here, but if you recline a casualty, kind of a 45-degree angle, and you measure the flick of their jugular vein and measure it above the manubrium, that gives you a rough central venous pressure, very rough. So you subtract that from your MAP, divide it by your cardiac output, and that's your systemic vascular resistance. It is a calculation that's helpful. It gives you a trending, but it's not something that's going to be the first thing I look at. It's not my big 3, right? So this is something that if you forget, if you don't know this, if you don't remember this, not a big deal. But it's something that I would encourage you to come back and watch this video when we upload it into your Moodle page, your my.quorum.org page, and watch this. And you can also do some research in PubMed. That's where I found this calculation, and see how you can calculate your SVR. And then you get trending. So once you get a number, you know what? Who cares what the number is? Just you get a number, and that's your SVR. And then every 15 minutes, you recalculate this, and you see your SVR slowly going up and up and up and up and up, or going down and down and down and down. So that's, if you have somebody that you're treating for anaphylaxis, you give them an epinephrine drip, and you want to see the change of SVR over an hour. So it's a really good indication on how successful you are. So here is how you calculate your non-invasive hemodynamic variables. Your systolic, diastolic, and MAP. It's easy enough. And I put here the more difficult, more precise equation for determining your MAP. Your CVP, you can assess this using jugular pulsation. It's in our field guide, page 32, I believe, the yellow section. And now you can, using all of that and your cardiac output, because we figured out cardiac output is pulse pressure times heart rate times 2. So that's, now you have enough, you can calculate your SVR. So how do we put this into context for remote medic? So when you're working on an expedition, climbing Mount Killy or Base Camp Everest, how is all this useful? How is this going to help me out? So let's start using some casualty, some patient, we'll use some case studies. We have 5 of them, I think, that we can go through in the last 20 minutes that we have. And we're going to use your hemodynamic variables that you now know how to calculate to assess your casualty. It's going to give you a better understanding of what's happening to your casualty. And as you do treatment, you can assess the value of the treatment you have. So as a normal paramedic on an ambulance, none of this matters to me at all. I give a bunch of blood in if he lost blood. I give water in, there's normal saline if he lost normal saline, and give him to an emergency department, kick him off to the curb, and we'll go back and have a pint. I can't have a pint, I'm working, but have a cup of tea. But you want to be an austere critical care provider. This means that you need these skills because you're going to be sitting with a casualty for a long period of time. And yes, you've learned your prolonged field care. You have a good understanding of your enhanced trauma assessment. These variables are going to tell you how successful your treatments are. Sure, putting a pelvic binder on is going to help with the bleeding. Giving him a TXA is going to mean that his clots aren't breaking down. So your treatments, you can use your hemodynamic variables to see how successful your treatments are. Instead of just giving TXA, waiting till the next 8 hours to give TXA again, and just sitting around waiting, watching what's going on, why not use the skills you have now as a critical care provider that will tell you in a more profound way how your treatments are doing? So your austere critical care is more than just doing hemodynamic assessments. It's doing hemodynamic assessments to see, trending to see if your casualty is getting worse, and trending to see if the treatments you're doing is getting better. So you're working in Tunisia with the UN. One of your coworkers begins to show signs of hyponatremia, meaning that he has altered mental status. We call it umbles. He's stumbling, umbling, fumbling, tumbling, grumbling. So all of these things say something's wrong with the head. And this guy is going into hypovolemic shock from environmental problems. So let's bring up these hemodynamic measurements and our pumps, pipes, and fluid. This is our cardiovascular system. So on the left, we have MAP, heart rate, cardiac output, central venous pressure, and systemic vascular pressure. My question to you is, you have someone going into hypovolemic shock because they've been sweating and not drinking, and it's super hot in Tunisia, and they are now unresponsive or they say they're pain responsive, and they are in hypovolemic shock. So this is of the pumps, pipes, and fluids. This is a fluid problem. So your systolic and diastolic are going down because they're in shock. So their MAP is going down. To compensate, you're absolutely right. Those of you that answered, is your heart rate's going to go up to compensate because your MAP is going down. Your body isn't getting the oxygen delivered that it needs. So it's going to increase the heart rate, which means your cardiac output is going to go down. Your CVP is going to go down, and your systemic vascular resistance trying to compensate, meaning the pipe is going to get smaller, and they are going, therefore your SVR is going up. So using the skills you have, I mean, obviously you treated this casualty, you did your CABC, and you're going to give him, let's see, what fluid did he lose? He lost normal saline, sweating out, and we need to give normal saline back. We're not going to give him blood, even if we have it, because he just needs fluid. So we start pumping full of fluid. And this is when we are going to assess, using these variables, we're going to assess how well our treatment is. So as a normal paramedic without critical care training, we would have to wait a bit longer. We would, all right, we're going to give them 2 liters. It's starting out in the late 80s and 90s. We gave 2 liters of saline to everybody. You sneezed, you got 2 liters of normal saline. And we would just whack it in there. We'd be like, let's say, oh, he's getting better. There we go. Ah, grand. He's talking to us now, and let's take him in. So that's not good enough. You're better than this. So whilst you're waiting for the results of your treatment, you can be getting your variables and trending every 5 minutes and seeing what these are doing. So good. That was a fluid problem. Next casualty. You're working in Malaysia. When you're with your company's embassy, one of your diplomatic staff begins to show signs of a heart attack, and she goes into cardiogenic shock. So is this a pump, pipe, or fluid? So what hemodynamic measures are we going to expect? So we have a problem with pumps, pipes, or fluids, one of them. This woman went into cardiac arrest. So, I'm sorry, was it cardiac? It was not. It was cardiogenic shock. So not quite arrest. All right, heart rate's up, SVR is up, everything else is down. So you're saying MAP is down, cardiac output is down, CVP is down, and heart rate is up. Good. And another response, MAP is getting low, heart rate is low, cardiac output is low, SVR is up, and CVP is low. So the difference here is cardiac output. So with a broken pump, is the cardiac output going to go up or down? In a normal, so last one we had a fluid problem. So hypovolemic shock due to neurogenic shock or anaphylactic shock or hypovolemic shock. So your pump is fine, so it's able to pump faster. But this time the pump is broken. Is your broken pump going to be able to pump fast enough? Sometimes in cardiogenic shock, it's a broken pump, and it won't. But your heart rate can go up. You're in shock. Your MAP is going down. Your cardiac output is going down very quickly. Your CVP would be normal or up a bit, and your SVR would be up a bit. So this is a pump problem, a cardiogenic pump problem, and depending on the contractibility, the ability of the pump to contract, depends on is the heart rate going to go up or down. But the heart rate is going up and your MAP's going down on this. So what this is telling us, so we have an embassy staff, old lady that has she collapsed, she has cardiogenic shock, and we're going through our ACLS algorithms to treat the cause and go through our H's and T's to figure out what's wrong with her. And we can use these 5 hemodynamic variables to tell us what treatments we're doing are, if they're correct, if they're working or not. Good. So that's a pump problem. Casualty 3. You're working in northern Canada in a remote drilling site. One of your pipe fitters gets stung by a bee and begins to show signs of a shock. And we're going to say anaphylactic shock. Hypovolemia due to anaphylactic shock. So here is anaphylaxis. It's one of the more common hemodynamic problems we're going to see in a remote and austere environment. So anaphylaxis, we're looking at pumps, pipes, or fluid. Which one of these? Is it a pumps problem, pipe problem, fluid problem? And I want you to answer me on, or give me an answer on these 5 variables. Are they going up or down because of anaphylaxis? So this is a pipe problem. Anaphylaxis means that the mediators are causing the pipes to get big and leaky. There's fenestrations, there's big holes in the pipe. So the vast amounts of normal saline is being lost, and the pipe's fine. It's going up a bit, but the fluids, the same amount of fluid is there, but it's just not getting around because of the pipe. So SVR is super down. Good, Tawheed. You're absolutely right. Cardiac output is equal or could be little up, a little down. It just kind of stays in the middle. Heart rate, well, it's shock. So heart rate's up, trying to compensate. Good. MAP is dropping like a rock. Good. And CVP is down as well. So we are going to do our races mnemonic, remove the antagonists. We're going to give antihistamines, epinephrine, salbutamol, fluids, whatever we can to treat this pipe problem for anaphylaxis. Good. All right, next scenario, casualty 4. You're working in Syria in a makeshift clinic. The locals bring in a teenage boy who is 3 days post-injury in a collapsed building. He's showing signs of septic shock. What hemodynamic measurements would you expect to see on a septic shock patient? So pumps, pipes, or fluids? Which one of this? Is it a pump problem, fluid problem, pipes problem? And for a septic patient, is the MAP going up or down, heart rate going up or down, cardiac output, CVP, SVR? So MAP is down. Well, it's shock. MAP is going to be down. Heart rate's up. Cardiac output, about the same. Central venous pressure is down, but systemic vascular resistance is way down. We need to give this guy epinephrine and antibiotics as soon as we can. Good. All right. So here's the take-home message. I promised I'd give this to you, and I would encourage you. This isn't our field guide, but I would encourage you, if you don't have our field guide, to review this video and look at the relationship between the 5 types of shock in the hemodynamic measurements. At the college, we bundled, so we have limited this out to just 5 main types of shock you're going to see in an operational environment. So we call it CASHN. So cardiogenic shock, anaphylactic shock, septic shock, hemovolemic shock, phenolemic shock, and neurogenic shock. These are the 5 types of shock. And here are the variables that they're going to be with all of these hemodynamic, non-invasive hemodynamic parameters. So heart rate, or respiratory rate, well, it's shock. They're all going up. Heart rate, they're all going up except for neurogenic shock. The heart rate is going to go down. And for BP and MAP, they're all dropping like a rock. In cardiogenic shock, your BP is going to go up, but your MAP is going to go down. So your central venous pressure, they all go down except for cardiogenic shock and your systemic vascular resistance. Cardiogenic shock, they go up. So MAP, look at MAP, they're all going down regardless. And with cardiac output, they're all going up except for septic shock. So this is just something to look at with your field guide when you're in your clinic to help you see trending and see how your treatments are affecting your casualty. So hemodynamic monitoring is pumps, pipes, or fluids. And we have the ability to find parameters in non-invasive parameters, calculate them, measure them to give us a glimpse, and not as good as a central line, but it gives us a glimpse to see how our hemodynamic system is doing. And if we're giving, when we're giving treatments, we're going to see, using this methodology, we're going to see improvements or not improving, and we can adjust our treatments going off of this hemodynamic monitoring. So in summary, we wanted you to understand the basics in hemodynamics. We wanted to interpret some of the hemodynamic monitors and the variables that are non-invasive ways to find variables, and differentiate between shock states using these hemodynamic parameters. So if you have any questions, you can send an email to courses@quorum.org,